Good afternoon, everyone. Welcome to the American Enterprise Institute. I'm Tom Miller, resident fellow at AEI. We're in a bit of a lull week where things are not moving as they've pretended to move for the last couple of months. The efforts in the Senate for repeal and replace ended up in delay and depart for recess week, and perhaps more to come. What it first taught me to, and let me just tell you, today's forum is called Unbundling the Benefit for Better Health, a broader role for health savings accounts, and more on that in just a moment. But in light of the Senate efforts, what I was thinking of is a older competition that used to be held for young athletes between ages 6 to 15 to show their skills in the NFL. It was called the punt, pass, and kick competition. It appears that that's actually being discontinued. The announcement came in May after more than 55, 56 years of it. But it looks like the Senate is up to the task in terms of punting, passing in the more throw-it-aside sense, or kicking approach. And we'll see how much more that competition renews when the Senate is back next week, and perhaps for the balance of the month as well. I had to be a little careful with this because the NFL is rather aggressive on its trade name protection. So this is a news shot as opposed to violating any NFL ordinances on pass, punt, and kick. And besides, they're leaving it behind because they want to just give everybody now a certificate for being out in the field, I guess, kind of like soccer, rather than doing these more elongated skills. We're starting today a different series of health policy events. Everybody's been caught up in the politics of what's been going on, and I thought I'd try something different, which is flesh out some things that people are doing in real research, as opposed to moving the dollars around from one place to another, and some interesting articles that have appeared in some of the policy journals. So what we want to do is talk about, given no matter what you're spending, we could do a better job in the health care and the health we deliver by perhaps taking apart what is conventionally considered the current benefit, and then maybe reassembling it in somewhat more creative ways, which pay attention to the people who are receiving those benefits and might have some voice in saying what works for them. So today's version of Unbundling the Benefit talks about how health savings accounts could be used. But we're going to have some other events later on this fall which talk about how to perhaps re-engineer and restructure primary care, which would combine using a different mix of services, but also in some cases for certain types of patients or individuals with high-cost, high-risk conditions, giving them a little bit more of an intensive care unit type approach when it's necessary in order to head off things that might go on further. That's probably coming up on September 5th. We'll also take a look at how to move around the dollars that are nominally included within the Medicaid benefit to perhaps retarget and prioritize them in a different way in order to ideally get some better results, and also maybe look at the distinction between what is said to be equal benefits for everybody, everything the same for everybody, as opposed to what might be more equitable benefits where people get what they need in different amounts in different situations in order to think about what it produces. Today, though, we're looking at some new ways to deal with health savings accounts. Now, at the end of the day, health savings accounts, and they have a long history, and we'll hear from our speakers on that, are essentially tax-advantaged health benefits. Now, you can move that around. There are other ways you can do it. In fact, some people have talked about using health HSAs in so many ways. You could say it's almost like a Swiss Army knife. It doesn't just do this, it does 5 or 6 other things. Of course, if you don't have any money in your health savings account, it's a good hypothetical tool, but it might be a little dull in terms of where it can cut. Give all credits to this on the product. I think that Victorinar is the only manufacturer of the Swiss Army knife, because I looked for some shots on that. That's why there's a little bit of a logo in there, unless I missed that. Or MacGyver, perhaps with some chewing gum, could also take care of our entire healthcare system. So the idea of the health benefits is to move around those tax advantage dollars so they actually produce more bang for the buck integrated in one form or another with health insurance. Now, you'll hear from our speakers, there are some current proposals as to how to change the contours of HSAs, but there are also some more creative and thoughtful ways to reach beyond even tweaking here and there on the margins. And we have 3 speakers today, and our first speaker is going to talk about how to have a more precision approach to HSAs. It's an early way to think about this, and I'll introduce the 3 speakers separately. Lauren Roth has just begun a new appointment teaching health law and legal writing at St. John's University School of Law, once known as the Red Men because they became unfashionable. Now they're the Red Storm. We adjusted that on the campuses. But Lauren has also served as Associate Director of the Lawyering Program and an acting assistant professor at NYU's School of Law. Earned a PhD in political science from Columbia University. Also previously a law degree from Harvard. Has clerked, done legal research and writing work at Seton Hall, and has a hometown connection, I suppose, because she graduated from George Washington University. I ran across a fascinating article by Lauren thinking about a different way to think about health. I've had some of those thoughts in the past, but usually they calm me down. It's a combination of how we can produce better health with a broader array of tools, including investments in some of the social services and ways to improve social determinants of health in order to get the results we want, as opposed to just paying some people along the way who have health care bills. So Lauren's article is going to be appearing in the Cornell Journal of Law and Public Policy, date to be determined, as they always say. But let's have Lauren talk a little bit about a different way to look at HSAs and a number of layered approaches to getting there. Lauren?
Okay, thank you. And thank you for having me here, because I will say that typically I'm talking only to academics, so it's nice to have a broader audience here to talk about HSAs. I wrote this article immediately following the election, thinking, what are some areas where there's potential bipartisan support? And HSAs seem to me to be an obvious one. I think the conversation is even more urgently needed right now, given what's going on. So I will give a little bit of background information on the HSAs, hopefully not stepping on the toes of the other presentations. And I expanded the amount of background information I was going to give because last night I was at dinner with a friend from college, and he said to me, you know, I think I might have a health savings account. And after, one question from me, it turned out he did not, in fact, have a health savings account. He had a flexible savings account, right? So I think for, this person is one of the smartest people I know. He's a lawyer in DC. I think if people like him don't really understand very much about HSAs, then my guess is that a lot of other people have no idea and don't really understand how to use them if they do have them. So there's been a lot of talk about HSAs in the media, following the politicians. So health savings accounts, or HSAs, are part of the movement for consumer-directed health plans, CDHPs. There's a whole lot of acronyms involved in the movement, FSA, MSA, HRA. Maybe that's why people can't have trouble distinguishing between them, because they get lost a little bit in the alphabet soup. So it's all part of the general shift that started with pensions from a defined benefit paradigm for employee benefits to a defined contribution paradigm. And what do I mean by that? With a defined benefit paradigm, your employer basically promises you a benefit now or in the future. You will get $2,000 a month for retirement income. I will pay for all of your healthcare expenses minus maybe some co-payments. To a shift where the employer will place some amount of money, if you're lucky, into an account, and you will really have the control and the freedom to figure out what to do with that. What are your benefit priorities? Now, of course, the problem, as we talked about, is if there's not enough money in that account, which I'll return to again throughout my presentation, then it's not all that much help to you, right? If you don't have the money to purchase benefits and to provide for your needs, then those accounts, which have a lot of potential, are not that useful. So there's a big divide, a political divide, about these individual accounts. So Republicans, including President Bush, who enacted the legislation for HSAs, tend to really love the individual accounts. It goes along with the American ethos of individuality and control and ownership, the idea that people can decide for themselves what their needs are and act on those needs, that you don't have this paternalistic employer telling you what to do and providing for your benefits in the way that they think is appropriate. Democrats, on the other hand, tend to think that individual accounts shift the risk to the people who are least able to bear it, right? So Democrats are focused on the fact that there's not enough money in the accounts, right? Maybe the accounts in theory would be a good idea if they were fully funded, but they're not, right? So Democrats see it as a way of cutting back on benefits. So talking a little bit about the basics of HSAs. So the way it works is that HSAs must be combined with a high deductible health plan, or an HDHP, not to add to our alphabet soup. So instead of traditional private health insurance that covers all of your medical care needs, with an exception for some co-payments, maybe some co-insurance, but covers your medical needs starting from day one, with an HDHP, your traditional health insurance coverage doesn't start until you reach a pretty high threshold, right? And before that time, either you're responsible for paying out of pocket, or you can use your HSA, if it has money in it, to cover those costs. And I remember when I graduated from law school in 2004, I spent my whole first year working with employers to put in place these HSAs and these HDHPs. And at the time, people, were up in arms, about the HSAs and thinking, this won't be good enough. People won't have enough of their expenses covered. Today, people are lucky if they have the HSAs, right? Because whether they want to or not, most people have been shifted towards higher deductible health insurance plans, and frequently they just, they would love to have an HSA that had some money in it. So I'll talk about, so the high deductible health plans don't kick in until the threshold, except for an exception for preventive care. The ACA requires that they cover some preventive care. But beyond that, there's this hole before your insurance kicks in where you have to pay for the expenses. And on the next slide, I'll talk about the numbers. But Professor Yee is going to talk a little bit about the tax advantages of HSAs. As she mentions in her article, it's an incredible savings vehicle, triple tax savings, right? So your contributions to the HSA are deductible from income, the earnings grow tax-free, and withdrawals from the account are not taxed if they're used for qualified medical expenses. And that's really the focus of the article I've written, is what are account holders allowed to spend their money on, and how I think it should be different. So money can only be used for medical care as defined under Section 213D of the Internal Revenue Code. And this is a definition that originally applied to a deduction in the tax code for people who have excessively high healthcare expenses. So right now the threshold is 10% of income, which is an extraordinarily high amount before the deduction kicks in. But when the whole CDHP, consumer-driven health plan movement kicked in, this definition was expanded to apply to that whole alphabet soup. All of these individual accounts right now are using that definition, which I think is pretty out of date. And we'll talk about how health law scholars are focused on other things beyond traditional medical care. So what you see now, these are the 2017 numbers for HSAs and HDHPs. HDHPs have to have an annual deductible of at least $1,300 for single coverage or $2,600 for family coverage. And there's a maximum for annual out-of-pocket expenses, deductibles, co-payments, but it's a pretty high maximum, right? $13,000 for a family is, for most people, they would start rationing their health care far before they got to that point. Employers and employees can contribute up to the maximum aggregate limit, which is, the congressional proposals work on expanding this limit, but right now it's $3,400 for single coverage, $6,750 for family, and there's a catch-up contribution for people who are 55 and over. So right now, Roughly 19% of employees are enrolled in an HSA qualified HDHP. That's very careful language, right? That doesn't necessarily mean they have opened up an HSA. That doesn't mean there's any money in the HSA if they have opened it up. So it makes it, you can see from the numbers below that 25% receive no employer contributions at all. Right? And the average employer contribution of $1,200 for family needs to be balanced against the current average annual deductible for a family of over $4,300. So there's about a $3,000 gap between what the average employer is contributing to the HSA and the deductible where the insurance really kicks in. There are, as people have discussed and continue discussing, there are a lot of drawbacks to HSAs. Obviously, I don't think they're insurmountable, or I wouldn't have written the paper I wrote. But the biggest drawback, which we've mentioned before, is that you need to have money to fund them. Sarah Rosenbaum, who's a health policy professor at GW, said it's a non-starter for people with low incomes. I think that's true right now, right? In terms of the amount of money going into HSAs, I don't think it needs to be true. It's just another vehicle for getting money allocated for healthcare to people, right? That's really all these accounts are. So it has great potential in my view. The great risk shift, which I talked about before, Jacob Hacker at Yale has done a lot of research on this. Employees now are paying, if they get switched from a traditional health insurance plan to an HDHP, they're paying more of their medical expenses than they used to, right? This is where Professor Yee's work will come in, right? Not everyone is being switched. Some people are gaining new coverage. But obviously, employees are bearing more of the cost than they did before. And the idea is that it may not be such a bad thing, right? Healthcare expenditures are pretty tremendous. We want to find ways to limit them. We want people to think more carefully. Are they using unnecessary services? Are there ways that this could, force people to think more carefully about their medical needs? But the problem with that is that, studies have shown that consumers are not fully rational when it comes to health expenditures. And there are a lot of reasons for this. First of all, unlike other goods that you might do some shopping around, it's pretty hard to shop around and look for competitive prices when you're sick. Obviously, if you're in a hospital and you need emergency services, this is difficult, but even if you're just not feeling well, the idea of calling 5 pharmacies to find the best price on a medication is pretty unappealing to most people. And you can imagine that this would add burdens to the system that are not currently there. If the pharmacies then and the insurance companies, everyone had to be there answering individual questions all day long about the prices of services. The other problem is services may not be comparable. How do you value cancer treatments at Sloan Kettering versus the same treatments at a local hospital? How do you deal with the fact that people have a very subjective attachment to their doctors, right? And may be willing to pay more than they rationally should to see a particular doctor. And a couple other reasons. Hard to know if the services are even necessary. So forgetting that it may be hard to compare prices, people are relying on their doctors and on experts who know more about medical care than they do to understand if they even need these treatments. So it's a little bit hard for individuals without a medical degree to second guess the doctors and help to ration their own health care. And the final point I wanted to make is that studies are showing, and I list a couple here, that people are rationing their own health care and avoiding needed medical treatment because they don't have enough money in their accounts. The idea is that you want people to feel the cost, right? With traditional health insurance, people have no skin in the game, so they have no incentive at all to limit their services that they consume. But here maybe now there's a little too much skin in the game, right? And maybe people are choosing to spend the money on other things, which is where my research comes in. And in terms of it being complicated, you know, this comes back to my friend, if you're not even sure you have an HSA, the learning curve involved with opening the account, making contributions, making sure you have enough money to meet your needs, and then using it, getting reimbursed. It's all pretty difficult. Current legislative proposals, and I won't say too much here because it's in such a state of flux, but beyond the most recent proposal I heard from Senator Cruz, the HCA and the Senate bill, the last version of it that I knew about, were really focused on doubling the contribution limits to HSAs. To $5,000 for single coverage and $10,000 for family coverage. And again, this is a nice idea, but if a lot of people don't have money in the account, upping the contribution limit, which people are not reaching anyway, doesn't really help that much. Focused on giving people more flexibility. Some of the things I mentioned there, I think the most important one is really reducing the tax penalty when money is not used for qualified medical care. And the reason for that is you may have some people avoiding putting money into these savings accounts because it's unpredictable, right? You may hear some figures like, in retirement you'll need $200,000 for your medical care, but you don't know that. And if people are going to have a really large penalty if they pull the money out and use it for something else, they may be reluctant to save using these vehicles. Okay, so now to my proposal, which I'll spend the rest of my presentation talking about. My proposal is for something I'm calling precision HSAs. And these are HSAs that are funded by employers, employees, but also the government. And they can be used for a broader array of goods and services depending on the account holder's family income level. And I list, I'll go back in detail in a minute, but I list the steps, and you'll notice that step one is to fund the accounts, because it's hard to experiment and use the money for interesting things if only the wealthiest Americans can really afford to fund their accounts. Step two is to allow physicians or other health workers, because there are huge costs to the system from having physicians prescribing better housing for you, let's say, to prescribe a broader array of goods and services. And this is where the catchphrase social determinants of health comes in, and I'll explain more about that in a minute. Step three, I really don't believe that my proposal requires amending the definition of medical care under the tax code. I think it's more about having agencies and courts reinterpret this phrase, given the changing state of medical care, the changing research on the impact that the social determinants of health have on health outcomes. So the current definition of medical care is that you're allowed to get a tax deduction or to use your HSA money for expenses that are, quote, for the diagnosis, cure, mitigation, treatment, or prevention of disease, or for the purpose of affecting any structure or function of the body. So it's a pretty broad definition, but the definition is the same for everyone. And it's focused on traditional medical treatments instead of other things that might improve health. And here we're thinking about housing and education, things that are being linked in research that's being done to health outcomes and better population health. The US spends an enormous amount of money on healthcare. And I say healthcare even though we really spend most of our money on medical care, and I'll explain the difference. But we spend over 17% of GDP on healthcare, and yet we have much worse health outcomes than comparable countries that are spending much less. So I think that the time has come to spend on different things. And I'll just give a few examples of what the current definition does. So the current definition of medical care includes what you might expect: doctors' visits, hospital services, lab services, the cost of medications, transportation to and from medical treatment, and the cost of some improvements in your home that are made for medical reasons, but it's fairly limited. It excludes things that are, quote, and this is in the regulations, not in the statute, merely beneficial to the general health of an individual, such as a vacation. And I have a few slides that give some examples. So, and this is how finally we're parsing it. So, what's an example of something that's okay to use your HSA funds for? An air conditioner which is detachable from the property and purchased only for the use of a sick person. What's not okay? Apparently purchasing an air conditioner that prevents everyone in the house from overheating during a heat wave, including members who are in their 90s, let's say. And this is again from the regulations. A doctor suggested that a taxpayer install an elevator in his residence so that the taxpayer's wife who's afflicted with heart disease will not be required to climb stairs. Also, the cost of installing swimming pools is frequently deductible, or you can use your individual accounts for it. What's not okay? Paying for pest control services to prevent roaches from making the asthma of children worse. And this is another extreme one from a case. Taxpayers were allowed to deduct the cost of enrolling their son in a school, a college prep school, as a result of drug and behavioral problems. And the cost they were allowed to deduct included tuition, room and board, airfare and rental cars to and from the school for therapy, and an allowance account for the child. But what's not okay? Well, you can't use those funds for ordinary education expenses for the poor that are strongly correlated with improving incomes and also improved future health. One of the things that got me started thinking about changing the definition and personalizing the definition of medical care are recent changes to medical care itself. The movement for precision medicine, which is also called personalized medicine, is focused on using an individual's genetic code to predict future illness and to tailor treatments for current illnesses. There aren't many presentations I give where Angelina Jolie's name appears among the slides, but this is one. So some people—
That'll improve the internet search results.
There you go. There you go. Now everyone will find our talk and be more interested. So people who are testing positive for certain genes related, for example in this case, to increased risks of breast and ovarian cancer are having prophylactic surgery. Cancer drugs are being targeted to particular genetic mutations using immunotherapy. These are just some ways in which medical care is becoming more personalized. And it made me think, if we're personalizing medical care, why hasn't the interpretation of the term medical care under the tax code changed at all? And why should the definition be the same for everyone? What if people need different treatment to prevent the disease? And what if different things are affecting their bodies under the definition because they live in different environments? So what I think we should be spending more on or focusing more on are the social determinants of health. Scott Burris, health law professor, defines the social determinants of health as the contexts in which people live, learn, work, and play. And the basic idea is that those who have higher levels of income live longer. Okay. Now, the causal relationship for this is not entirely understood yet. But then again, a lot of medical treatments that we pay for and believe in this country also have no scientific studies that prove that they're effective. So why are we not spending money on things that clearly seem to be showing improvement in population health? And as a little extra incentive, I put in there, I don't know if I have that, yeah. In a more unequal society, apparently the rich don't live as long as they do in a more equal society. So it's interesting, it's also affecting, it's not just affecting the people who can't afford these services. There's something that's affecting population health overall. Okay, and I'll fast forward a little just to make sure I stick to my time. But my proposed definition is that we spend more on health care, which I define as any attempt to improve the health of a person, including both increasing longevity and quality of life. And I think of medical care as something that takes place more often in a hospital or in a physician's office, even though that's changing a little bit nowadays. But healthcare frequently starts at home with a change in lifestyle. Okay? Small changes can have a big impact. And examples that we're thinking of here include a babysitter to help you recover more quickly from surgery if you can't otherwise afford one. After-school programs for your children so they can get exercise and not become obese, not have diabetes, fresh fruit, vegetables. Okay. And so the idea for me is that if there are things that are as important or more important than medical care, then we should be paying for those things or allowing people to do so. So funding the accounts directly or through grants to the states where the states are funding the accounts, you know, more and more of the middle class and the working poor have access to HSAs and HDHPs, but it's very important that government tax expenditures focused on improving healthcare not cater only to the middle class and the upper class, the people who can already afford to put money in these accounts. And to me, this could be about sort of changing the default rules, right? Different people in different income brackets can spend on different things, right? So maybe people in the higher levels of income would pay for these things regardless, but a lot of people can't afford to. It's also a way for the government to incentivize certain types of spending that will improve population health, okay? And I think I will stop there.
All right. Okay. Thank you very much, Lauren. You can think of this as outsourcing the welfare state to the people who are supposed to benefit from it, where they make the decisions rather than get whatever's on the card in some limited categories. Now we're going to park that for just a moment in terms of a different way to think about how to extend or restructure tax advantages for healthcare and better health. We're going to now look at the possible coverage effects in some surprising results that our next speaker found with regard to the combination of these HSAs and the higher deductible policies related to it, as to what that effect might have in terms of some portions of the population, as whether or not it makes coverage more accessible to them, and some subsets on that. Our speaker is Jinky Yi. She's an assistant professor in economics at Huazhong University. I was told to say that fast, so you couldn't tell whether I pronounced it properly. The Huazhong University of Science and Technology in China. She did receive her PhD in economics from Syracuse in 2006. I came across a excellent article of hers in the Journal of Health Economics, which was December of 2015 on this subject. Our primary research fields are health economics and public economics, with a particular focus on examining the effect of healthcare and tax reform on insurance coverage and working behaviors. In addition to this article, the effect of health savings accounts on group health insurance coverage, she also has another paper, the spillover effects of health insurance benefit mandates on public insurance coverage, evidence from veterans. Jinky?
Mm-hmm. Sure.
Right
there. Okay, good afternoon, everybody. And first of all, I would like to thank AI for inviting me here to discuss my previous research. And I think I feel great pleasure to present my research work on health savings account today. So I believe that because we have a lot of experts about this policy today, so I think our discussion will definitely help me to improve my future research. And my presentation today will be the effect. Oh, okay. Can press this. So my presentation today will be the effect of health savings accounts on group insurance coverage. So I would like to thank my PhD advisor, Len Berman, who is also sitting here. So his previous research about medical savings account actually inspired me to looking at these specific policies. When I was a third-year PhD student, have no idea about how to start a research project, so he definitely helped me to have a hint to looking at this interesting policy. I find this health savings account very interesting because it is a combination of healthcare reform and tax reform. So I would like to spend time to do some research on this specific policy and to trying to find some empirical evidence on whatever outcomes I would like to look. So thanks for Lauren, and she has already gave us a lot of specific details about these policies, and I think can help me a lot to save some time. And also, she presents some updates information about this policy, since this work is about publishing 2 years ago. So some of the data numbers here are just like 2010 or something, but I think you guys can observe a trend of the change of the policy, such as the contribution change or the deductible change. And I think I can start from the motivation of why I want to look at this effect of policy on group insurance coverage. Since, according to my understanding, when we think about the healthcare market or health reform, a lot of researchers and policymakers will focus on two fundamental issues. The first one is whether the policy or reform can improve the health insurance coverage. So to obtain this goal, the government has already made a lot of efforts. So as for the group insurance health, or ESI, the government has already have a lot income tax subsidies to the premium part of our health plan. And also, as for the public health insurance, we also have a lot eligibility expansions, especially under the ACA setup. And also for individual health insurance, we also got the marketplaces to expand the market. And during the process that we would like to expand the health insurance coverage, the second fundamental issue we would like to concern is about during the process to expand the health insurance coverage, how can we improve the efficiency of healthcare spending? So I think when I'm doing my research on health savings account, I would like to fit the policy design of health savings account into those fundamental issues. So I find that even though we already have a lot income tax subsidies to the premium part of health plans, actually we don't have any subsidies for the out-of-pocket expenditures before medical savings account or health savings account. And also I think the major function for design the health savings account is to help us to improve the efficiency of healthcare spending. Because health savings account establishment is just to help the individuals save for their futures, and they also want to help people to be more sensitive to their health spendings, since they have more self-controls for those monies in that account. So I find that health savings account is very perfectly fitting in those fundamental issues, so I think researching on this project will be very worth to do that. And as for the definition of health savings accounts, it is a tax-free healthcare expenditure savings account, and it will allow individuals or families to contribute to this account, and they are totally tax-free. And of course, it can help them to save for their future out-of-pocket health spendings, and the criteria for being eligible for holding this the accounts is they purchase the eligible high-deductible health plans. And according to my understanding, as long as the people should purchase the high-deductible health plans to be eligible getting those health savings accounts, I think it is a behavior to shift the premium component's tax subsidies into the out-of-pocket component. So I think it is a totally interesting tax reform, just using the transfer of the tax subsidies. And as mentioned to Lauren, Lauren also said they have the triple exemptions if you have the tax savings accounts. The first is that health savings account deposits are not subject to the personal tax income. And the second one is if your withdrawals are used for the tax expenses, they are totally tax-free. And the third tax advantage is that with unwithdrawn funds in health savings account can be accumulated and used in the future. So that means if you cannot, so you can totally save when you are young and you can use the money when you are old. And also the interest earnings on this deposit are totally tax-free. So compared to other tax-preferred accounts such as IRAs and 401ks or even physical savings account, I think health savings account has more tax advantages compared to others. And also I ran into the same situation with Lauren, and my friends called me to ask me, my firm seems like to provide the health savings account, so can you explain what are they? And at that moment, I feel like my research are very useful because I can help people to make their choice about health plans. So I'm so glad I'm researching on this field. And okay, so I will very quickly skip this part since this one is the old numbers. I didn't update the numbers, but you can still observe a trend compared to Lauren's presentations. So I also show some criteria for the high deductible health plan, which can make you qualified for health savings accounts. So when the year was in 2012, the deductible level is a little bit higher or lower? Can you tell the 1,250?
It's gone up.
It's like the same?
It's gone up.
Okay. And the maximum contribution is also, you can either contribute the high deductible health plan deductible or $3,100 for individual plan, whichever is lower. And for the family, you can contribute the high deductible health plan deductibles or $6,250 for a family plan, whichever is lower. And also, there's one specific rule for health savings account which I was using in my empirical analysis, is that the HSA holders between age 55 to 64, they can make additional catch-up contributions of 700 in 2006 and rises by 100 annually until it freezes as 1,000 in 2010. So I will use the information to do my empirical evidence later. And also, here comes the important part. So health savings account established in federal law in 2003, and the state laws passes in 03 to 11 plays a role in the use of health savings account by providing state tax exemptions to parallel federal tax treatment. So before I run into the empirical studies, I want to show some facts about the people taking up the health savings accounts, eligible high deductible health plans. So the panel A figures show there is an increasing trend of the number of people with HSA eligible high deductible health plans. From 2004, there are like 0.44 million, increases to 13.5 millions in 2012. So we can observe there is a dramatically increasing number of people who having this kind of plans. And the panel B just choosing the angle of the firm to show us there is still increasing trend for firms who offering these plans and for employees who taking up these plans. So we can both observe there is an increasing trend for each side. And under my understanding about this policy, I think HSAs may expand the group insurance coverage from employer side and employee side. For employers, I think they would be more likely to provide the HDHPs for better consumer engagement and cost control through HSA's legislations, especially for those small employers who haven't to provide any plans to their employees, and because they face relatively a high risk to the future compensation cost. But after we have the health savings accounts, they may think the health savings accounts eligible high deductible health plans may be a good choice for those firms. And also for employees, they also got the incentive since the low premium of HDHPs paired with the tax break of the health savings accounts may be attractive to those who got the access to group insurance, but they haven't taken up any of it. So my research question turns to, does the establishment of HSAs income tax subsidies expand group insurance coverage? And my identification strategy is actually using the policy variation by state and year. So remember, I introduced the federal law and the state law. So I would like to explore the variation of the state HSA implementation, actually. So the federal law implemented the federal income tax exemptions for contributions to health savings accounts. And at the same time, the state governments can choose to mirror federal tax treatment by offering the state income exemptions or not. So I would like to use this variation in state legislation in several years because I think it provides an excellent laboratory for learning the causal effect of providing HSA state income tax subsidies and the probability of the worker getting health insurance, group insurance coverage. So to do that, I first using the existence of the policy. That means I just using the policy dummy to identify the effect. And the second step I'm doing this project is using the parameterized state tax price, a state health savings account tax price to measure the actually effect of the tax subsidy level, so it will be a more accurate effect. And this table will show us the time of state health savings account legislation between 2003 to 2011, which is my research period. I show each state have their year of health savings account implementation, and also I show the state without any state tax subsidies, or the state have no state income tax. And so the equation here is my main identifications. It is a very simple equation. I followed every empirical, the classic empirical specifications using those state policies. So the Y is just a binary measurement. So if the worker I is covered by insurance, group insurance, I will give them a 1, and otherwise it's 0. And my key variable here will be the HSA. So first of all, I put a dummy here. So HSA equals to 1 if the state has health saving account state income exemptions in year T-1, give 1 year lag to let the people have the reaction time, and 0 otherwise. And for this specification, I also control for a lot of individual characteristics, just as marriage status, age or educational level, and occupations, etc. And I also control for state fixed effect and year fixed effect. The data I'm using here is very common source. It's just the CPS data set, the March supplement from this 2004 to 2011 from iPumps. And I limited my sample to age 55 to 64 years old workers and with no Medicaid coverage. So this table, I would like to show the summary statistics of my whole samples. Maybe the number here is a little bit small, but the main takeaway for this table, I just want to show the comparison of the individual level characteristics for the health savings account states and non-health savings account states. And for each type of states, I separate the sample to the whole sample, the older age group, and the small group, and the less educated people. And I didn't find any dramatic differences between those groups, but anyway, I control for every characteristics I can in my model, so I think I'm safe now. And this table is the first empirical evidence I would like to show you guys. So I use the nonlinear probit model and the linear model to compare the results. And as we can see, the column 1, I just report all the associated marginal effects with their standard error. It will be more easier to interpret. And according to the results, I don't think the health savings account's existence significantly changed our group insurance coverage for the whole sample. And the reason why I think I got this small and insignificant positive effect, positive coefficients, is that maybe it's due to a lot of unaffected population now. So I'm thinking about just separate the sample to see whether there is a specific cohort will be more sensitive to be affected. And so this table just shows the results when I separate the age group by 10-year bracket. So from column 1 to column 4, so you can observe the pattern of the effect for the youngest group to the oldest group. So as we can see, the column 4 will give us a positive and significant results. My interpretation about this coefficient is that when you are a worker between 55 to 64, the health savings account subsidies will increase the group insurance coverage by 2.6 percentage points at 5% significance level. So my hypothesis is that the younger group can be very sensitive, since I guess they may be attracted by the low premium plans, but at the same time, the older group may also be sensitive, since they have a better idea to save for their health, since they have this opinion to do these things. And also the older people may have higher income, so their tax incentive may be much better than the younger one. So anyway, the column 4 testify my second hypothesis for those age groups. And I also trying to use the linear, and I find the results is very consistent. And the second cohort I would like to check is the small firms. Since I have already mentioned that in my hypothesis, the small firms that doesn't provide any insurance plan to their employees previously may be more sensitive to those health savings account eligible high deductible health plans. So I'm just simply adding one interaction term of the policy dummy and the indicator of small firms. So I'm trying to use different cutoffs to test my sensitivity of results, and I find it's not very significant different. So if I'm using the 25 employees as the cutoff of small firms, I find a positive and significant results for the interaction terms. So the marginal effect is showing in the bracket, square bracket. So that means when we have health savings account subsidies, the small firms workers will be increase their group insurance plans 2.4 percentage points more than other employees. So it's consistent with my hypothesis. And the third cohort, I would like to check whether they are very sensitive to health savings account eligible high deductible health plans is less educated people. Since according to some previous literature, looking at the effect of, the plan choice of those consumer-driven health plans, they have different opinions about whether the high educational people or low educational people will be more likely to be affected. So I'm trying to look at whether my conclusion is consistent with theirs. So I still adding one interaction terms with policy and the less educated indicator. So I using high school here. So I find that the interaction terms also give me the positive and significant coefficient. So that means health savings accounts is increasing the people with lower educational level 2.5 percentage points more than the other workers. And after I using the policy dummy to identify the effects of health savings account, I'm figuring that the dummy can only test the effects of the existence of the policy. But if I want to go one step further to looking at the effect of the level of tax subsidies, I need to find a more accurate, like the more accurate variable to identify the effect of tax subsidy level. So I'm trying to using the tax price of health savings account contributions, since the definition of a tax price is the cost of $1 of tax-favored item in terms of current after-tax consumptions. So to help us to understand that, I give you an example. So if the tax rate is 0.2, that means the tax price of this tax-favored item will be 1 minus 0.2 equals to $0.8. So the tax price of HSA contribution can just replicate the definition to here. It's the cost of $1 of such contribution in terms of current after-tax consumptions. And because health savings accounts will involve the federal tax rate and state tax rate, so that means if I want to find the tax price of health savings account contributions, I need to find out what is the state tax rate and the federal tax rate. So I'm trying to input the top marginal federal rate and state rate by year to calculate the tax price for each state and year. And I'm using the taxing model of the NBER and to put every number for every state and every year. So the variation in tax laws across state and year can be assumed as an endogenous to an individual decision. So I think the maximum income tax price are very nice independent variable to using in my regressions. And taking Minnesota in 2006, for example, I use the marginal federal income tax rate for the top bracket is 32.9 for Minnesota in 2006, and the marginal state income tax rate is 8.01%. So my health savings account tax price now will be 1 minus these two numbers, and we can have the answer here. So for each state and each year, I calculate their tax price, and I just simply replace the previous policy dummy using this tax price to redo all the analysis I've just shown you. And this table is just organized all the results here. And as we can see, the tax price, the single variable here, can still give us insignificant coefficient. But when I'm using the interaction term of the tax price and the interesting cohort I have already shown, they have more sensitive behaviors. So we find that the negative 0.185 can give us a conclusion that when you decrease the tax price by 10 cents, or in another word, we increase the tax subsidies to those accounts 10 cents, you can have nearly 2 percentage point increase in your group insurance coverage. So that's the way I interpret this number. And also, we can also observe negative and significant results when I just using the interaction term of tax price and lower educational level. So that's most of my empirical results, and because of the time limits, I will skip all the robustness check after the empirical studies. If you are interested about the later process of this project, so you can just go there and check the paper. So finally, we come to my conclusion and policy implications. So according to my empirical evidence, I find that the HSA state income subsidies expands group insurance coverage for certain important subgroup of population. For example, the older workers who are aged 55 to 64, and the small firm workers and the less educated workers. And the magnitude of the effects are around 2 to 3 percentage points. And as for the policy implementations, I think, according to some previous works about the consumer-driven health plans, they have already found some evidence that they have the ability to control the health spending increase. So I think the positive effect I found in the paper can tell us, assuming mechanism that the health savings account subsidies can help increase the coverage of HDHPs, and then they will increase the total number of group insurance coverage. Even though I cannot test directly about the channel, since the data limits doesn't allow me to observe the specific plan choice of every workers, but I'm still trying to find a new data set to do that project. But I still think the health savings account subsidies paired with those high deductible health plans have the function to moderate the cost increases, and they can also promote the health spending cut through those policy settings. And when I just finished the project, I feel like I'm so lucky when I'm looking at the new rules of the ACA. Since the ACA is more likely to promote a comprehensive health plans, so I'm trying to find the evidence that my health savings account eligible high deductible plans can still be effective under these settings. And I find that it's very qualified for the ACA bronze or silver health plans. So I think under the circumstance of the ACA, the existence of those plans can help the mandatory coverage more achievable for the employers who are facing steeply increasing healthcare costs in the future. But recently, I think the ACA will be soon replaced by something else, and I think the health savings accounts eligible HDHPs will play more important role in the future health reform. And because really appreciate Tom give me a lot of new reforms rules about ACA, just like the increasing the maximum amount of contributions, and also they will let the spouse to have the catch-up contribution to the accounts. So I think it's kind of consistent with what I'm finding here. So I think the empirical results can be still have some implementations for the future reform, and I will still pursuing to see the future impact of those reforms on the health plan choices and the cost savings or even the health outcomes. So I think that will be a very interesting field to study.
Thank you very much, Jackie. We know health policy researchers only need two things: another data set and some policy variation, and that keeps them in business. Actually, back to me, I want to pass over, to oversimplify this. It's wonderful, we always knew these worked in theory. Now you're actually providing some evidence for it as well, which is just a total bonus. But for the political implications of this, I want to run back to something earlier in terms of some of your sub-cohorts. The effects on the less educated. I slid over this before. In terms of the real political implications on this, you need to go back to, we got a ways to go that way. Given who's currently in the White House, you might want to recall the Nevada caucuses or primaries in February of 2016, and the comment of the successful candidate at that time. Let's find it right there. There we go. Donald Trump loves the poorly educated. So HSA should be a winner on that one. And if you want to, because I have copyright restrictions, you can find that on YouTube for the verbatim result of that. Now, we loved a lot of other people who voted for him. But I think that suggests a bit of a correlation and a convergence in terms of let's favor this policy because it helps the base. Our final speaker is Roy Ramtham, who could have given continue a 5-hour discussion on HSAs, because he does know just about everything, whether he's Mr. HSA or other names along those ways. Roy is a nationally recognized expert on health savings accounts and consumer-directed health care issues. He was there, if not at the birth, certainly at the time of the delivery. He was both obstetrician and pediatrician when it came to HSAs. So other people claim to be the godfather, but Roy did the hard work in terms of actually keeping things alive and moving them on to maturity. He was at the Treasury Department in their implementation of HSAs when they were enacted into law in their full form in 2003, and then he worked for President George W. Bush as health policy advisor at the White House to carry on that work, and also develop the implementation of the Medicare prescription drug benefit. And he's been involved for a number of years and is back doing it again. Was the founder originally, president again of HSA Consulting Services, with all kinds of useful information and advice on how these operate, and speaks about it. Long experience in health policy, including on Capitol Hill, Senate Committee on Finance. He's worked in the administrative agencies at the Healthcare Financing Administration, went into witness protection, now known as Center for Medicare and Medicaid Services, under a new name, same rap sheet, I believe. And Roy also has worked in private industry, and I won't hold it against him that he went to North Carolina, but we'll take that outside later on, and also at the University of Michigan. Roy, I asked Roy to both comment on the two presentations and then elaborate a little bit further, because he has his views on policy and what's evolving beyond that. Go ahead, Roy.
Thank you, Tom, and thanks for including me today. I think it's important to kind of keep the historical context of HSAs in mind in all of this. They kind of take on and use the existing tax preferences for medical care. To my knowledge, we haven't changed the definition to health care yet. It is still medical care for a reason.
I'm lobbying for that.
I understand that.
Keeping a lot of people in this audience in business.
And that's quite all right. You know, HMOs were at their heyday when HSAs really started to be created back in the medical savings accounts day. And there's, I guess, with your criticisms of the definition of medical care, maybe we should be calling them medical savings accounts because of that reason. But regardless, the name has been changed to health savings accounts, and I would argue that, you know, they've made a lot of positive impact on a lot of people. As Dr. Ye mentioned, not only on the coverage side, but also addressing some of Dr. Roth's concerns about the uses of our healthcare dollars and what they can be done with. We have to recognize that insurance is complicated. And for the all the things that we say negatively about the name high deductible health plan, because that usually sends people running to the exits, they are actually simpler health plans to understand than many traditional plans, where you have to know the co-pay or co-insurance rate for every service. Under a high deductible health plan, if it's not preventive care, which is free, it's subject to the deductible. And so whatever your deductible is, that's how much you're going to pay. After that, the insurance was going to pay the lion's share, maybe 100% even, depending on how the plan is designed, up to a final limit on out-of-pocket expenses for that year, which many of us have forgotten about because we're so focused on the deductibles and how high they are. Insurance is also use it or lose it. When you pay your premium, most of us kind of hope that we don't have to use it, because that might mean that we're really hit by a bus or some other horrible thing happening to us. And others of us think of it as a gift card, and we just go as often as we want because somebody else is paying the bill, so we don't care. But insurance doesn't cover everything, and what they do cover is more medical care, I would argue, than health. And we call it health insurance, but it really is medical care insurance. And there's been many criticisms of our whole system of healthcare financing being more of a sick care model than really a health promotion model, which is what HMOs were designed to do, is try to change that focus to maintaining and improving health rather than just taking care of people when they were sick. But during their heyday in the mid-90s, they also came with a lot of restrictions. You couldn't get a second opinion, or you couldn't go out of network and get something covered because those kinds of restrictions were put in place. And HSAs were partly a response to those restrictions, where if you have your own money to spend, you literally can go see any medical professional that you want and pay for it with your own dollars. And so I think the real innovation that HSAs brought to the table was to give the same level of tax treatment to the out-of-pocket expenses as to the insurance. So our tax code since the World War II days has been heavily biased in favor of employer-based insurance, and also medical care purchased through insurance. So if you don't have access to those two things, you don't get tax benefits that other people do. And HSAs really come and give those tax benefits to people who cannot get those tax benefits through their employment, don't have access to them, or maybe self-employed. And also then the out-of-pocket expenses that all of us have, which insurance does not always cover everything. And employers have provided other options before HSAs came along, known as flexible spending accounts, health reimbursement arrangements at a later date, all of which predated HSAs and have similar concepts and tax treatment for these types of services. Although I would argue FSAs and HRAs are much more grounded in 213D in terms of their lack of flexibility and types of services that they can cover. So with this change and having tax parity for the out-of-pocket expenses, it's no longer necessarily in my interest to spend all of my tax-preferred dollars on insurance that covers everything with little out-of-pocket expense, because I can literally get the same tax treatment for my out-of-pocket expenses through the HSA. Even better, the money that I put in the HSA is not use it or lose it, as my insurance is, as my FSA is, as typically the HRA alternative also is. And so the HSA can cover many more quote-unquote non-medical things that are health-related, not as far as the broccoli and kale caucus would like us to go at this point, but steps in those directions, which I think is a positive thing when we're looking at health. Most of us do not measure our healthcare spending based on what it does to improve our health. And another criticism that came from the HMOs was it is the HMO administrators or your employer who is rationing your care. Now it is you. And who would you rather have ration your care? Somebody you don't know or somebody that you do, with the financial choice that goes with it. We also found that a lot of things that afflict us and affect our health actually get better on their own without any medical care. So for all the studies that I read about, people used less services, people didn't go get this, people didn't go get that. Okay, I understand that. That's one way to measure this, but did their health suffer as a result? That's what we need to be measuring, and I think that's one of the things that you're trying to suggest with your paper, is that we need to be looking at a broader determination of what is health, and does the utilization of all these healthcare services have such an impact on their health. I'm happy to see HSAs be part of the health reform discussion, and I thank Dr. Ye for looking at what those impacts were during those early days when data was a little bit harder to come by and often got a little complicated to really understand. I do think that the data is suggesting that one of the main tenets of HSAs was right on point. That is making coverage more affordable, which would lead to increased coverage, and we definitely are glad to see confirmation of that. I also remain hopeful that the analysis of the state HSA subsidies, using your terms, will finally convince the 3 holdout states, California, Alabama, and New Jersey, to finally conform their laws to the federal tax law. I remain skeptical that they will actually do so, but I can always remain hopeful. I also think that the paper is very useful in understanding kind of the world of HSAs before the ACA came along. Your research somewhat conveniently stops about the time that the ACA comes into play. So we need to keep watching these trends, looking at during the ACA, and if we get to such a point where we're post-ACA or whatever comes next, that we continue to monitor these trends and look for what does the data suggest. Because I think it is fascinating to look at the subpopulations of individuals and their individual coverage choices. We know that employers are driven primarily by the bottom line, and when they can save money on premium, they will do so. Thankfully, the bulk of them, it appears, are sharing those savings, maybe not all of them, with their employees in the form of HSA contributions. And one of the things that I try to work with employers on is making sure that the lower paid employees who need the most help, who are at the greatest risk with their deductibles, that the employer focuses their contribution strategy on those lower paid workers, as you suggest. Those of us who have greater means are likely to be able to fund those accounts with our own dollars, probably don't need the HSA subsidies as much as the lower paid workers. So maybe that's another area to look into over time as to what is the impact of these employer contribution strategies, not only on employee participation, but also their adoption and utilization of these programs. To Dr. Roth's paper, I generally support the notion of making HSAs more flexible, and I'm glad that Congress, who is now involved in so many of our tax policy decisions, has seen fit to introduce some legislation that would take some steps down this road. Most notably, a bill introduced by Senator Orrin Hatch, the chair of the Senate Finance Committee from Utah, and Congressman Eric Paulson, who's a member of the House Ways and Means Committee. And this bill would really go a long way, I think, in taking some of those incremental steps, at least, maybe not as far as you would like us to go at this point, but not only to allow more Americans to have HSAs, but to raise those contribution limits and provide more flexible uses for the HSA funds. And it gets into things that are more along the health spectrum, such as allowing individuals to use their funds tax-free to pay for certain exercise equipment and physical fitness programs, which I would argue also needs to be on our lists. Some diet and nutritional supplements, again, things that could be helping us maintain our health. And so we need to look at those ideas and maybe be combining them with the broader concept of health and not just limiting it to medical care. I suspect that in the short term, the IRS and those who are our budget scorekeepers will tell us that this will bust our budget and will lead to a dramatic increase in tax expenditures until we figure out a better way to capture the impact on our health and the longer term payoffs. Goodness knows that we've had lots of discussions at the Congressional Budget Office also about the value of preventive care and does it pay off in the long run for the short-term costs that it incurs in the meantime. I think your paper also raises interesting possibilities for social policy where we might want to be looking at HSAs and other social benefit programs and how those concepts of the accounts could be combined in ways where food subsidies, housing subsidies, healthcare subsidies could be combined in ways that are much more flexible to be used. Right now they're very siloed based on which department created the program and the rules that go with it. Congress sometimes has something to do with that as well. And maybe they could be used in a much more holistic manner. The challenge that we have, though, with those things are, at the end of the day, is there a slippery slope that we end up falling off of completely because we don't know where to set the ends? And should anyone be enforcing, if you will, at the end, what some of those rules or limitations might be? I do remember my days at the Treasury Department when our HSAs were being created, when we were trying to do the same thing for defining preventive care, which would not be subject to the deductible. And believe me, we were lobbied by pretty much everyone saying that everything they did was preventive. It prevented something.
And if it wasn't, it would become it.
Absolutely. And so not everything can be preventive. Not everything can be prevented either. And we sometimes go back and forth a little bit about whether or not we actually trust Americans to spend their own money appropriately. And a recent example of that is some conservative Republicans who don't want HSA funds to be used to pay for elective abortions. So on all sides of the spectrum, there are views on what people should be allowed to spend their money on, whether it's your favorite vegetables or yoga classes or what have you. I'm in favor of things that promote health, but we need to understand where there are limitations, and do we really want the IRS, somebody who is not trained in health policy, to be making those decisions at the taxpayer level? Absent that, we may have to accept some limitations on these subsidies as a trade-off for that flexibility. So with that, let me stop so that we can engage in broader discussion.
Thank you, Roy. You certainly did mention the dreaded magic word at the end, trade-offs, which we don't want to. You know, these accounts would work perfectly if they were 100% funded for everything, because we may be trusted to spend our own money, but some people don't trust you to spend someone else's money, which is the public-private. So let's talk a little bit about those gradations and those trade-offs. One thing that implicitly was in there, if you're spending the funds in the HSA for other things that don't fall under the category of traditional insurance, you're then going to have a trade-off in terms of filling that gap before you reach wonderful 100% coverage insurance land. And given where that would tend to create larger out-of-pocket requirements before you get into that insurance, we might be better off by diverting it, but there's going to be a gap. There's less gas in the tank and your mileage may vary. So work through that, because if the money's not infinite, it means a choice. Hopefully it's a choice to do something that pays off better.
That's right. This is Tom being nice to me because I talk too much and letting me kind of finish what I left out at the end there, which is great. So absolutely, that's true. If people can spend HSA funds on other things, there are two things that come with that. A, they may be left without money to pay for traditional medical expenses, because one of the things is that you're bearing the risk, right? Maybe you think housing is more important today, but tomorrow you get hit by that bus, right? So I think a lot of it is that, first of all, you know, obviously, again, not to harp on the point, but if we're talking about the fact that currently there's not enough funding in those accounts anyway, they're facing this choice anyway. So if step one is to put money in the accounts, then the question is, what do we do about the fact that if they can spend it on other things, there might not be money left over? And I think this may be where we get to the point of, you know, having some different, you know, where there may be some different pools depending on income levels for insurance. Just because insurance, all types of insurance besides health insurance are typically used to cover those catastrophic expenses, whereas in this country we rely on it for pretty basic care as well, although we're shifting the cost now to individuals. So I think there are still ways to make sure that even if there is a gap, we can lower deductibles and have different deductibles depending on income classes. There are different ways that we can do this, requiring the government to bring down some of those costs. The other issue is just that if individuals, is the impact on the providers of these HDHPs. So if people get to the deductible sooner, because they're spending both on traditional medical care and on other things with the HSAs, then this will mean that they're using the expenses for these insurance companies will of course go up because more people get to that deductible and require services provided through the insurance plan. And I think there's no way around this. If we're going to give people more money and they'll get to that deductible sooner, it's going to require some kind of subsidies to the insurance companies. I don't view this as a bad thing. Like Tom was saying, the trade-offs need to be made. I just think we've been making them in the wrong direction, in particular for certain income levels. I think that we need to be focused on things beyond just traditional medical care.
If I could just add that, we don't bat an eye sometimes when people go out and use their insurance for things that really have no value or low value. And some would even encourage us to not get some of those services.
Right.
But then we argue over whether or not people should be allowed to spend their own money on other things. So it is kind of interesting to engage in that conversation.
Let me frame it a little differently. I was given the Swiss Army knife analogy before, and maybe there weren't 6 or 7 blades in it, but in terms of the pro advocacy arguments for here, it seemed like you've got at least, and you have more if you want, 3 distinct potential things you're trying to accomplish through more HSA account-based flexibility as opposed to the one-size-fits-none insurance wrapper. And Lauren is talking at times about the distributional benefits, which is maybe we can resort this money so it goes to people who need it, and we're going to have to be a little more reverse income sensitive because the tax code works the exact opposite. The progressive tax code structure means the benefits are regressive, just the way it's wired. It's simple math. So you've got the distributional arm over here. Then you've got over in the middle is this flexibility. I just want to be able to move this stuff that I want to. And then occasionally we hear, well, you'll have a different time horizon. Or I talk about it. You're going to save it. Well, it's hard to both save this money for the future and being able to use it on what you want right now. So it's another straddle. And I just, how do we create an opportunity for not the single answer? That in fact, there are different settings in different places. And we want to do all those things, but we can't do 100% of each one of them at the same time.
And the problem is also that everybody, they're trying to give a benefit to each group just to get these things passed, right? So like you said, traditionally, if we're using tax expenditures, then the people who are reaping the most reward from them are the people who are in the higher brackets, right? If you have a higher marginal tax rate, then you're getting more of a benefit when you get to deduct this money from your income. And that is, I think, why the HSAs have become such a savings vehicle for people in the upper middle class, the upper class groups, and we're seeing increasingly high account balances. Whereas, the legislation that's aimed at increasing contribution levels is only going to accelerate that trend. So you have this huge gap that people at the lower end have no money in their accounts, and then a lot of people are using it to save for, healthcare, medical care expenses 20 years down the line. And I think that that's part of where the trade-offs need to be made. I would not be increasing the contribution limits, to be honest, because I think too many of the benefits then are going to people who already have high account balances. So I think if we're going to take those dollars, and I forget what the figure was, 19 billion, whatever the figure is for what the current proposals to expand the contribution limits, how much that would cost, I think we need to focus on using these accounts to redistribute money. And I think that's why, to some extent, HSAs still have a bad rap on the left, is because we're not talking enough about distribution.
Sounds like we just need to do everything at once and pay not attention to what
that doesn't seem to be working so well,
I've
doing everything
that
now at
as
once. Yeah.
Tom, if I could just jump in on the contribution limits. So they're designed to achieve parity at the out-of-pocket limits under these health insurance plans. And I would argue that that really is the protection that the sickest of us need. I'm going to spend those expenses out of pocket. Would I prefer to do them on a tax-advantaged basis? Absolutely. And the nice thing with the HSA is I can do that after the year is over, between now and April 15th. So I don't have to worry about predicting. Sure, there'll be some people who take advantage of it just because they're thinking about the future. Many of us need to start thinking about the future because every study I show says that our healthcare expenses in retirement are going to be a lot more than most of us are thinking of. And that's after what Medicare is covering and typically does not cover long-term care.
Well, let's talk a little data for a second. Roy, you probably has a handle on this as much as anybody. Actually, I was looking at a AHIP survey, and they had the image of a piggy bank on the cover, which I thought, yeah, that says something about how people view on that. We all know our childhood savings, and some people keep it in there, and other people don't put any in. We want to do many things. Pay for our insurance premiums. That's the cruise approach with all this money that we've accumulated in the bank. Where are we in terms of, and there are averages, and there are medians, and then there are, subsets, in terms of how much can really be parked effectively without already being spent along the way. Let's say you're a diligent person, you're careful with your health care. How much can you accumulate over a longer period of time without suddenly something happens and you need to, get out there? So the idea that at age 65, how much have you actually got in the HSA? And what do we know right now about how much gets saved looking ahead as opposed to needs to be spent anyway?
Yeah, unfortunately, most people think of HSAs just like a new and improved FSA where it's money in, money out. And so the S part of HSA still means spending to them, not savings. So that's something that the industry has been working on, trying to get people to understand there is a strong savings component for this account. And the average contributions are going up every year, but very slightly. And we're still only at about an average of $2,400 a year, which is nowhere close to where the maximums are. Obviously, there's great distributions within that, and you have some that end up with zero balances at the end of every year because they don't understand. I've had the same experience as others have. Oh yes, I have an HSA, until they tell me that it's use it or lose it, and then no, it's not. So that happens, and there are other people on the other end of the spectrum who are looking at this as simply as a supplement to their retirement savings. So you get every walk of life in here, and I think as HSAs grow and become more mainstream, we're going to get more walks of life in there than we've had before. And so it'll be a new group of people who have to understand what HSAs are, what the potential are for them, and how it can help them meet their particular needs.
I just think of a different, when we're moving by analogy, because you worked on the Medicare drug benefit as well. The donut hole is going to be somewhere. Do we let people move it around to where it matters to them more practically? In other words, you can have it at the front end. In the drug benefit, we temporarily put it in the middle, although that's been negated over time. Or you can do the more limited benefits, and I've had people lobby me on that one, to say give people what they need right away and don't worry about, I don't have any assets, so I really don't care about that catastrophic expense. Is the default to basically say there's a lot of places, but you're going to have come up short somewhere? Or do we think that we can pretend that everybody's fully insulated from having some risk without a pre-funded benefit?
I mean, I really am erring on the side of focusing on immediate needs. I think that if people believe that these funds are better spent elsewhere, then that's where they should be spent. Also, I think there's this, fundamental misunderstanding of what we really need to be spending on to improve health. And yes, I know the FIT Act, as I think it's called, is paying for gym memberships and things like that. And that's, something else that could be helpful. But I think people living in dilapidated housing conditions, it's very hard for them to focus on the tiny percentage chance that a bus could hit them when there is, technically a bus hitting them every single day of the week. So I think that it's the immediate needs. I really like the idea of integrating some of the other, the funding through other agencies and sort of having a more overarching approach because obviously I'm putting things into HSAs that traditionally are going other places. I think it's also hard because you don't always, if we were to customize things, then you also make for some great data so that we can have studies about what's working best and prove the health savings, right? Because the problem is that now all anyone wants to talk about are the dollars going out the door. And my next project that I'm working on is actually a study dealing with some policies that might save costs in the pre-Medicare population. Because it's very rare that you can actually say to people, if you do this in the 10 years leading up to Medicare, you'll save X number of dollars. Why wouldn't you spend on that? Unfortunately, it's just harder to do when you have such long time horizons, people have so many different needs. But I think we do need to start thinking a little more creatively than we have been thinking.
Jinky, I want to ask you a little bit more about your research. And I tried to go through every footnote and every manifestation, and sometimes you miss something along the way. A couple of threshold questions came to mind, although I know you're trying to show the incremental effects of the way in which state tax policy gave you the natural variation. You've got not just the holdout states that Roy was talking about, but you've got some states and some big ones, I'm thinking Florida and Texas, who just don't have an income tax.
Yeah.
Were you able separately, I know you try to control for everything, to say what was going on in those states over the years? Did they have a different growth pattern because they weren't enhanced by additional state tax advantages? Did that all, work out okay to basically throw them out of the pile, if I understand the way you did this?
I think that's a very good question. So I think the ideal situation to get rid of those states' effect is to just maybe don't let them in the sample and to try and to redo the test to see what happened. But I think there is only a few states that didn't imply the state savings accounts tax subsidies. So if I just throw out all the states with no tax income, I'm a little bit afraid about the variation issue. And to help me to do more sensitive checks, so I'm trying to control every state level's characteristics, especially for the health insurance plans. So in my robustness check, I controlled for the state level per year, their premiums level for individual and single thing, because I think if the state have no income tax, they should have something related to the premium, since the premium is also like tax exempted. So I'm controlled for that type of things, but still keep the states like California and Florida in my sample.
And you were getting about a 2.5% gain, which is, gains are good. Then the question is compared to what you do instead. And that's raised the issue of, is there a threshold level of tax advantage which accomplishes most of what you want to do?
Yeah.
And then there's an incremental effect beyond that, and what the variation is on that. Although we do love the poorly educated, I want to mention that.
Yeah, I really want to looking at the other data set to check whether the people does change their choice, because that's the key mechanism in this paper. So I'm trying to use some other data set, but that's coming from like some large firms. Like I'm trying to using some federal employees record, but I think the federal government is a very special like company to say. So I cannot find any significant effect of the changing. The coefficients are very small, but that's very preliminary results. I haven't dig more about that. But my sense is that this paper only find effects on small firms. So if I'm looking at some federal employees, I don't think I can find something there. So, but if there are any more comprehensive data set that including all type of firms, I think that will be very interesting looking at. And I think also very interesting to looking at some expenditure patterns for the people. Things I noticed that the health savings account can cover some like dental and vision care. For some traditional health care, you need to buy some extra dental coverage, some of the plans.
Which is usually considered dollar for dollar trading and not much of a deal.
So
Sorry, dentist, it's true.
So I think maybe it's also very interesting looking at the patterns of the expenditures for health. Is that the preventive care is covered by the health savings account money? It's,
preventive care and health savings, just like the Affordable Care Act makes it all free for everybody, is another mythical creation.
So
preventive, and you may have seen some proposals, the folks value-based benefits design saying basically you need to think about not just prevention in the pure sense of you never got anything, but given that you may have a chronic condition, how can you prevent it from getting worse? And that's an interesting redefinition of what is prevention, which is true, but it slides further down that scale, and eventually there's not a full tank of gas. And the question is, who should be and I think it's your point, Mark, who should be making those decisions? Someone at a distance or someone who's actually affected by it?
And I think it's interesting because people always bristle at the idea that anyone other than the individual should be making these decisions, but then they have a million caveats, right? But we don't want them to spend on having an abortion. There are a million things they want to add to that. So the question is, if we don't want the government doing it, who are we going to have physicians deciding it's what should be what's really important as far as healthcare and what people should be spending this money on. You can see the slippery slope there, and you can see how you get into all sorts of issues with different people from one to the next being able to use this money for different things, which realistically is just not pragmatic, right? So you have to have someone in the government making a decision within bands. If we believe people at different income levels won't spend for certain things unless it's with tax-advantaged money, then we have to. I understand the slippery slope argument, but we do. You do have to cut off somewhere, and if you don't make those decisions, then you just never have any funding at all for anything beyond hospital services and doctor's visits.
We're going to go to your audience questions in just another minute or two, and I want to go back to Roy, because Roy's actually had to deal with people at the IRS. They're difficult.
They're nice people.
Well, that's right. And once they leave the job, they have neighbors and families, and I'm sure they're very nice people, but it's a different role. So, the extreme version of this is the old Aflac commercial, Yogi Berra. You can give them cash, which is just as good as money. But eventually people say, what's that money going for? So we're substantiation, where we've backed off on that, all this nuisance paperwork, and maybe once upon a time or someday in the future, they might ask you to say, you got any evidence for this? But generally speaking, there's not a lot of backup for how people use the account. So if we expand the parameters further, should we just say, we think these people should get a certain amount of money. I hope they do some good with it, because we're not really tracking it very carefully, and let's cut out the nonsense of thinking categories. Or what's the other argument, which is you're safeguarding the taxpayers' money because you need to waste it on other programs.
It's a real challenge. Those who have celiac disease are probably going to be much more successful at getting gluten-free diets and the things that they have to eat to maintain their health before somebody like me who just has a shellfish allergy and I'm looking for subsidies for steak. Probably not going to happen in my case, where it might in the case of others. I think this does become the conundrum that we have to decide how far can we go, because I don't think the IRS even wants to be put in a position of having to make those decisions taxpayer by taxpayer. So can we provide clear enough guidance for people and expect them to follow it with good faith efforts, to not violate and sort of trust but verify as needed through random audits, which is our current process of doing it. I do think that that's probably going to be a reasonable approach. We could go as far as Professor Hertzlinger has suggested at Harvard, looking at the Swiss system where we measure people's health when they join their insurance, and 5 years later we measure it again and see if it's the same, better, or worse, and then decide whether or not we need to assess them accordingly. So, maybe there's some objective ways that we can measure everyone's health, and what you do to keep it there or make it better is okay with us. If it gets worse, then there's going to be somebody to pay at the end of the process, and we won't quibble about the details in between. I'm not sure what the right answer is, but we do have to look at the broader context of health well beyond medical care, I think, and Dr. Roth has got a good point in that regard.
All right, we've been a very patient audience and mostly attentive, I think. If we've got some microphones in evidence, if anyone has any questions or disguised editorials in the form of a swing in your voice at the very end, limited to a minute or so, and identify yourself, please let me know. Otherwise, you'll have to listen to my questions, and you don't really want to do that. Right there.
Hi, thanks. Steve Davis with Deloitte. We recently produced a paper on HSAs in the individual market, and we found there were surprisingly few HSA qualified plans in that market. So first, I'd like to get Roy's thoughts on why they're so scarce. And then for Dr. Roth, in the scenario that you discussed where the government, the employer, and the employee would contribute, how might that work in the individual market?
So as to the question of why aren't there more HSA qualified policies in the individual market, I don't think it was the priority as the ACA was being rolled out. Plans would have to meet not only the bronze or silver, in some cases gold's requirements under the ACA, but also be HSA qualified as well. And over time that has gotten more challenging, partly because some of the regulatory requirements as to what types of coverage those plans have to offer. For example, for 2017, the requirements began to be added of covering things below the deductible that were not preventive care. Well, an HSA qualified policy just cannot do that. It's prohibited under the law, and thankfully there was enough kicking and screaming that there's been a specifically identified HSA qualified bronze plan that can be offered for 2018, but it is hard to distinguish these policies from other plans in those categories that also have high deductibles, and you can't really tell which ones make you eligible for an HSA versus not. So as to why people would choose one over the other, I don't know. I think there's a lot of confusion in the marketplace, and until people understand the value that an HSA brings to the table along with their high deductible health plan, they may not decide to choose that.
So
Okay.
I should confess first that my preference, when the Obama administration did away and said we're not going to let employers give employees the tax subsidized money that they would have used to purchase the health insurance and let them go off and through HRAs, buy plans on the exchanges, I thought that was a big mistake because I thought the exchanges wouldn't be robust enough to survive. And I think, without propping up, they're having trouble now. I had envisioned, that, so we want to allow as many people as possible who don't have access to these tax subsidized funds to use them for the sorts of things that people who have those funds are lucky enough to use them for. So I had envisioned that really, a lot of it would be that these government contributions, all of this would be used to find converging, exchanges where you'd be able to purchase the plan and allocate between, expenses for the healthcare plan and the HSA money, having that slush fund to apply to other things. So I think it is still possible to have those contributions and to find the plans, on the individual markets, hopefully, that will allow you to use the money for other things.
So I'm very interested for your research, since when I'm choosing whether I'm looking at the group insurance or the individual market, I find that the individual market, the health savings account is kind of pure advantages, since the people in the individual market, they should have a lot of eligible plans. So is that not true in your case? So there is not so many qualified plans in individual market for the health savings account? Is that what you find? So what kind of plans in the individual market they offer, like very low premium, high premium but low deductible?
Well, we're looking at the exchanges. There really aren't many, as Roy mentioned, and just broadly in the individual market and our non-group market, there don't appear to be many HSA qualified HDHPs, or maybe they're not advertised.
I see. Okay. Thanks.
I know I had a hard time finding them when I was looking for them. I couldn't often tell by the name. And I think a lot more effort was put into the silver cost-sharing eligible plans to provide those individuals with the subsidies in addition to the premium subsidies. And I've actually done some modeling as to what individuals might be able to receive in lieu of a cost-sharing subsidy in the form of an HSA contribution that would produce the same actuarial value that those cost-sharing reductions would produce. And in some cases, it can be several $1,000s. So one has to wonder why not give the individual at least the choice of choosing their cost-sharing subsidy in one form or the other.
Yeah, cut out the middleman. Right there, I believe you had a question.
Hi, my name is Meredith Woody. I'm from the Health Resources and Services Administration. I have a two-part question. You had mentioned MSAs. One thing I found strange about the Senate bill is it mentioned in multiple places Archer MSAs, and if you could just clarify how you think that comes into play. And also the giving states flexibility when it comes to essential health benefits. You know, we talk a lot about how HSA currently under the ACA, preventive care is covered at no cost, even if you have an HDHP. Well, when you start tampering with EHBs, what's your opinion on how that's going to affect population health outcomes?
I'll start on the Archer MSAs. They were the precursor to HSAs as we know them, started 1997 after enactment in 1996 in the HIPAA law. No new Archer MSAs can be created as of December 31st, 2007. There are still Archer MSAs out there. We've tried to get it all converted over to HSAs. The advantages are clearly better under the HSA, but some still exist, and you will find them. And so some of these references in the bill are still artifacts of the legacy of the Archer MSAs. On the EHBs, essential health benefit requirements, you know, you do have a choice of whether you rely on the states to define them or you have a uniform federal standard. HSAs really don't care which one you choose, but whichever preventive benefits are required to be provided below the deductible would essentially be exempt from the application of the deductible under either scenario. So from an HSA perspective, I don't necessarily care who defines it and how it's defined. Just be consistent across the board and don't have a separate standard for HSA qualified plans from other plans.
Another question? Going once, and Joe.
Thanks. Joe Antos, AEI. Would the panel comment on HSA's connection to fee-for-service? You have to come up with a receipt for some approved service in order to get money out of the HSA. Do you consider that to be a barrier to further reform?
I personally have been growing in my concern of that fee-for-service linkage and HSA being tied to a receipt, as you say. I do think that medical care is evolving, and we're seeing much more bundling of services, packaging of services, which sounds like insurance, but in a lot of cases is not. It's just a package of services that maybe a diabetic needs a whole bunch of different fee-for-service things, but it's bought and sold in a package with one price. We don't always know how much of each of those pieces you actually get under that price, and I am concerned that the IRS at this point is not clear on how it would handle those types of situations. Fee-for-service is a very easy thing to gauge. You have a service, there is a receipt, we know what you got, how much you paid for it, and therefore how much comes out of your HSA tax-free. When I start putting other pieces together, I'm less certain about what you actually bought and what did you actually get. And should the tax code turn a blind eye to that, so to speak, and say it's all good, or the worst case in my opinion, saying none of it's good because it's all been bundled and we don't know whether you actually got any medical care or health care or what have you or not. So I think this is a future issue that we're going to have to grapple with. I don't think we have a good idea at this point how it would come out.
Len?
So I have a related question, which I think is just an informational question, but when MSAs were first being promoted, the idea was you'd go to the doctor, and because you were paying the money out of your own pocket, you could negotiate a really low price. And I thought that probably worked if a few people did it. It probably didn't work if a whole lot of people did. I'm pretty sure Blue Cross can do a better job of negotiating prices than I can. So under current HSAs, I mean, do you actually go to your doctor, get a receipt, and then you submit it to you submit it for reimbursement, or do you get the negotiated prices through your insurer? I would prefer the latter option, and I think probably most people would.
Fortunately, it is the latter option in most cases. If you're going to an in-network provider under your insurance, you generally will get the negotiated rate, and it's really up to that doctor's office how to collect the payment from you. Most of the ones I've gone to wait and submit it all to insurance and then bill me. They could be collecting what used to look like a copay, so at least they get some money out of me while I'm standing there in front of them, because I have seen some studies suggesting that people are not paying their bills when it comes to the pay and chase method. So if you are in network, you do get the benefit of the negotiated rate as opposed to the full billed charges. So that is a huge benefit to staying in network. Regardless of whether you stay in network or not, you could use your HSA funds tax-free to pay an out-of-network doctor just like an in-network doctor, although the amount would be different.
And a secondary concern, which is more than just with HSAs, is when you're out of network, that the insurance may pay at the contracted rate and you may pay the entire amount out of pocket. And when you get into public programs, you've got some disputes as to whether that's fully legal or not. There's another hand back there.
It's all still medical care.
That's right.
Thanks very much for an excellent panel. Andrew McPherson. I serve as director of the Smarter Healthcare Coalition based here in Washington. Smarter Healthcare Coalition is made up of a variety of organizations, U.S. Chamber of Commerce, AHIP, pharma, life science companies, and consumers, I might add. So consumer groups like National Coalition on Healthcare and Providers and others. We're focused exclusively on the issue that Tom brought up related to value-based insurance design and VBID. My question for Roy, or anybody that wants to comment, is legislation, bipartisan legislation on the Hill that is looking at expanding the current preventative safe harbor to include services and drugs related to one's chronic condition. So it's a limiting factor just to chronic conditions. And there's a whole variety of definitions used by CDC, CMS, and others for what a chronic illness is. So there is a limiting factor to it. But if the panel could comment on just expanding it to include, to allow health plans to offer those services on a pre-deductible basis.
Anybody else want to start?
So I unfortunately don't know as much about the issue as I would like, but I think this goes again to the fact that, like with a lot of my proposals, if you expand the definition of preventive care, obviously you're increasing the cost of the policies. So then the question is, you know, is that where we want to put the funds? Is there another way to help these people? I don't know what your experience has been with it.
Well, I actually have a lot of experience with this issue. And generally, I'm in favor of giving plans this flexibility to be able to do that. I know there are plenty of employers out there who are resistant to the specific HSA plan designs because they're concerned about individual employees who won't take their blood pressure medications, their insulin for their diabetes, et cetera, and they worry that without sort of compliance with those types of treatment options, that they will in fact face significantly higher costs down the road. So I do think that it makes sense to give health plans the opportunity to do that. It will cost a little bit more because there's greater coverage available under the plan, but the hope is that in the long term that will pay off in terms of controlling costs down the road. So I've generally been supportive of the approach.
And I just want to add one thing. So studies are actually showing that making these services that are designed to increase adherence cost-free don't actually improve adherence all that much, which is why, you know, the next project I'm working on is looking at going even further than your proposal, and really designing tax incentives to make them give a negative cost. Because, you know, studies are showing that to get the cost savings from improving adherence, you actually have to go beyond just adding them to the preventive care definition.
One follow-up.
Okay, go ahead.
Just to respond to that last point. So you can do it two ways. Either expand the current safe harbor, or you can create a new safe harbor, which is what the Access to Better Care Act in the House, Diane Black, Republican from Tennessee, and Earl Blumenauer from Oregon, a Democrat, both on Ways and Means, would do. They create a new safe harbor that actually doesn't remove, it still allows for cost sharing. It just would create the pre-deductibility for those services. And the idea is that, and Steve Parente, who's now at ASPE actually, or hopefully will be confirmed, and Dr. Mark Fendrick from University of Michigan have done a tremendous amount of research on this issue, and they've shown that it only would impact premiums by between 2% and 3%. So there's a lot of different ways to do it, but I think the core issue is this is a growing component of the market, as you said, and a lot of these folks have chronic conditions, and it creates a barrier for them to getting care, and as Roy was just saying, ultimately they may end up in the emergency room and cost more down the road. Thank you.
You're very welcome. We're nearing our time of closure and departure. Healthcare is pretty simple to solve, I think, as long as you have infinite resources. I'm reminded of a different comedy routine by Steve Martin about 3-4 decades ago. He used to say, "Steve, how do I become a millionaire?" And he goes, "It's a multi-step process. First, get $1 million. And then the rest is kind of simpler after that." So we're not in that world, and in fact, we are limited. What I think today's panel is saying to you is there aren't perfect answers, but the more that there's some flexibility and we can try to focus more on what this produces rather than what goes into it, and begin to align and integrate, because it's usually not just one person or one single individual or someone who's paying the bill. It's a commodity, a mixture rather, that if they're all pulling in the same direction and want the same thing, then we might get a little better aligned and at least get some more efficiency for what we're spending. But with that epitaph, please thank our panel for opening our eyes to some other ways to think about this, and thank you very much.